Chris, you're muted.
Thanks, Yuka. I don't think I'm in the correct mode. Am I in presentation
You're not
mode?
in presenter. Now you are.
Okay. Thanks so much, Eileen, for the privilege of talking today. This is, I don't think I can outdo monkeypox, even with an exciting presentation. But this is probably a little this is a little simpler of a presentation than typical, but hopefully a good send-off for what I hope is a good 4th of July weekend for everyone here. So like many of the presentations at this conference, there's a case. So I'll start with a case of a 65-year-old man with HIV on dolutegravir, lamivudine fixed dose combination, with hypertension on hydrochlorothiazide, presenting for routine HIV care. His last colonoscopy was at age 59. Sorry. And his last flu vaccine 1 year ago, last pneumococcal vaccine 7 years ago, and 4 years ago he had rectal gonorrhea. And he endorses depression due to a recent death in his family. On exam, his blood pressure is 135/82, otherwise pretty unremarkable. And his labs of note are an undetectable viral load and a creatinine elevated to 1.5 from his baseline of 1.2. Maybe not a lot going on here, but maybe if we just think about the primary care aspects, I've highlighted those here in green. Colorectal cancer screening, should he get colorectal cancer screening referral at this visit? His last flu vaccine was a year ago. Presumably this is flu season that you're seeing him and probably is due now. His last pneumococcal vaccine was 7 years ago. Is he due now for another vaccine that he's age 65? He's had a history of a STI a few years ago. What type of screening should be done? And his blood pressure is 135/82, although he's on therapy, so he has stage 1 hypertension. So I think the first is, I'm not talking about primary care and what to do, but I'm going to just present a little bit about what to do to get to the real point of this presentation. And if we start with colorectal cancer screening, here's an algorithm of consideration of the frequency that depends on what his last screening showed and what his family history is. And then the timing of the recommended screening can be anywhere from 6 months after his last colonoscopy to 10 years after his last colonoscopy. So all of those things will need to be considered and his prior history and family history reviewed. In terms of his pneumococcal vaccination, I realize AICP has an updated recommendation that's a little simpler. I included this simply because of its complexity. Depending on what he's received before, now he's turned age 65. So his recommendations are different. But anyway, depending on what vaccine he received previously, how many PPSV23s he received, and how recent the last one was, will guide what he should get at this visit. If we go on to gonorrhea and chlamydia screening, similarly, there are multiple considerations, including his risk factors, sites of risk, which will guide whether he should have 3-site testing and the frequency of the testing. This is just taken from the New York State guidelines, hivguidelines.org, but is similar to the CDC STI guidelines. Hypertension management, he's on therapy, but his blood pressure may not be at goal. I'm not even presenting an algorithm because there are multiple decision points based on age, what risk factor reductions have already occurred, and his cardiovascular disease risk score to provide an easy diagram. Then not related to this gentleman, but something I will be talking about later is TB preventive therapy, or TPT. Most of the work, research I do is related to HIV care and improving HIV outcomes in low and middle income countries, many of which have high TB burden. And for those individuals, TPT is recommended for all individuals starting antiretroviral therapy in those high TB burden countries. And this is just an algorithm to come to TB preventive therapy or isoniazid preventive therapy taken from a South African guideline. And you can see multiple branch points and considerations for before getting to the point of actually giving somebody TB preventive therapy. So that was just the basic primary care before we've even gotten to this individual's new apparent situational depression and acute kidney injury, which I've highlighted here in fuchsia. So at the beginning of a clinical day, certainly multiple considerations to juggle and try to get control of. And by the end of the clinical day, there can certainly be a considerable decision fatigue. And certainly my affect is often similar to the one shown on the figure on the right at the end of my clinical days. So I think first, what's the impact of the decision fatigue throughout the day? And here I just have the proportion of people living with HIV receiving selected guideline recommended care from a handful of somewhat arbitrarily chosen studies. First, for colorectal cancer screening from a single clinic in the US, 72% of the people in the HIV clinic had received either colonoscopy or fecal occult blood testing, and not necessarily up to date with it, but at any time. In terms of vaccination, hepatitis B vaccination at a single clinic in France, 62% of eligible had received that, 47% of eligible received hepatitis A, 64% of eligible pneumococcal disease vaccination, and 31% influenza vaccination. A study done by Steve Barry from the HIV-RN in the US showed that 39% of individuals had received appropriate gonorrhea screening. In terms of hypertension, from the US HIV Medical Monitoring Project, 49% of patients with hypertension were treated and controlled with their treatment. And then moving to low and middle income countries with high TB burden, on average between 20 and 50% of eligible individuals across studies from multiple countries have received TB preventive therapy. So in each of these categories, metrics far below what could be the goal. And I think we can now think about what happens when we don't reach our goals with dotting the I's and crossing the T's in terms of preventive care. And this is a paper that Dr. Gawande wrote for the New Yorker some years ago, but I think was really nicely done and really makes a lot of important points. And he looked at survival and then anecdotally some of the factors around patient survival at cystic fibrosis centers in the United States. And in 2003, the national median cystic fibrosis survival at dedicated CF centers was 33 years, which was a huge advance from a few decades prior when it was less than 10 years. However, at a few centers, the median survival was 47 years, so 50% better at a few centers than the national median, and that included a lot of high-profile, big academic centers that were just at the middle at 33 years. So he visited these centers and just anecdotally described what he observed, but one of them was a real attention to detail of the basic care at those best performing centers. They were really dotting the I's and crossing the T's, even when there was no acute issue, even when everything appeared to be okay, versus some of the median performance centers where acute issues often predominated versus addressing some of the routine care issues. If we try to see what happens in the general population with missed preventive care, there have been a number of modeling studies. This one is from 2010, and this is not HIV. If there's a study similar to this in HIV, please, somebody can let me know. I'd be interested in reading it. But this is just the general US population. And you can see in this figure on the x-axis, the percentage of eligible individuals who are receiving that service, and on the y-axis, the number of annual deaths that could be prevented with an increase from the current amount. And the current amount is the point on the left side for any one of these lines, and then an ideal situation or en route to the ideal situation, or the along going towards the right. And you can see with hypertension treatment that around 40% at the time of this modeling study nationally were receiving appropriate hypertension treatment. If 75% reached it, that may reduce, there could be a decline in mortality of 25,000 individuals annually. We look at another factor for the case presentation of colonoscopy or colorectal cancer screening. At the time of the study, about 55% of individuals nationally were receiving the right screening. If that was increased to over 90%, that could reduce mortality by about 5,000 deaths. And then with pneumococcal vaccination and influenza vaccine, probably a bigger impact on morbidity than mortality. But even in terms of mortality, increasing from the 60% estimated coverage to close to 95% could reduce several thousand deaths based on this modeling study. So I think I'm going to shift a little bit now to how to get there. And care delivery and uptake is complex. Lots of factors that go on. On the left are some of the factors for service delivery, and on the right, the other part of this equation, which is uptake of those services by the client or patient. Lots of things we could spend a lot of time discussing. I'm going to just focus on one, which is related to behavioral economics. And this is kind of a trendy topic. I'm going to, just as a refresher, briefly describe very superficially behavioral economics, and starting at the point of classical economics, which models behavior based on making a choice that will lead to the most happiness or the most financial gain or the best health, basically what would be considered a rational choice. Now, I think it doesn't take much insight or observation to realize that a lot of people make choices and decisions that even with all the information at hand, that do not necessarily lead to the best outcomes. The understanding of why that is and prediction of what decisions people will make is the basis of behavioral economics. Far more complex than I've described. A number of Nobel Prizes have been awarded by Kahneman, one, and another one to Thaler, both founders of this field. Within this field, there's an area of explaining deviations from what would seem to be the most rational choice or the best choice, which some of them are called biases. And one of the biases I'm going to talk about is present bias. It goes by a number of other names, including hyperbolic discounting. And another is cognitive load, also can go by the name of status quo bias. So getting a little bit more to what present bias is, this is the tendency of individuals to excessively discount the value of future benefits, while sometimes inflating the current cost or benefit. And something that even has minimal current present cost, which we can think of not as money, but just as opportunity cost, time, etc. Despite considerable downstream benefit, may be neglected because of that bias, that the excessive discounting of the value of the future is negated, while the minimal current cost leads to a failure to take that action. And this has been studied in a number of health issues. The reference here, Dang et al., is one of the studies by this author among a number, looking at the effect of present bias on human papillomavirus vaccination and its negative impact. That is the upfront cost to the clinician of time of explaining vaccination is a factor in the settings that were studied by that group in terms of reduction from the ideal amount of vaccination of a vaccine that obviously has well-documented morbidity and mortality benefit. This can be considered as the next visit syndrome when thinking about primary care. Preventive care can sometimes be kicked to the next visit because of the time or other relatively small present costs, despite the potential considerable benefit over time. Unfortunately, the next visit may happen, and then the next visit, then there's another delay until the next visit after, and then we get the delivery of preventive services that I already presented that is below ideal. The other bias or concept I wanted to introduce or discuss more, I'm sure everyone here is well aware of the cognitive load of providing medical care. Cognitive load can be considered the sum of the number of decisions and their complexity. And to make this seem scientific, I've created this little formula here that it's the sum of the number of decisions times the complexity. So even small decisions, if there's a sufficient number, can lead to considerable cognitive load. And the effect of that cognitive load is that the willingness to make decisions declines, can lead to decision paralysis, and the quality of the decision making also can decline. People are more likely to stay with the default, that is to have decision paralysis and not make any decision. And the decisions that actually are made are often worse. And this has been assessed in many different situations, most of them outside of the healthcare field, but it's been looked at in the healthcare field also. And in the figure on the left, this is a graph of colorectal cancer screening by the time of the primary care visit for a panel of providers working in the morning and afternoon. You can see on the left, the beginning of the day, 8 a.m., and on the right, end of the day at 5 p.m. And among a similar patient panel throughout the day of patients who are eligible for colorectal cancer screening, at the beginning of the day, about 38% were referred for colorectal cancer screening, the line in dark blue. Well, at the end of the day, it was down to about 25%. So a considerable decline, despite the fact that it's the same providers and the same patient panel. So classical economics would not have an explanation for that, because rationally, the patient and provider are the same at the beginning and end of the day, yet the decision-making has changed. Another example of worse decision-making with cognitive fatigue is shown on the right. This is a graph of management, again, in a primary care setting of acute pain, mostly acute low back pain. And the standard guideline recommended management for that is physical therapy and NSAIDs. You can see on the x-axis, the first 3 appointments of the day on the left and the last 19 through 21st appointment on the right. And here, just the difference in rate of providing various services for this acute pain. And in light blue is physical therapy. And you can see that even though this is evidence-based therapy for acute low back pain, there's a decline in providing that. NSAIDs are in yellow-orange, and those stay pretty stable throughout the day. Well, opioids, which do not figure into management of acute low back pain in nearly all situations, rise throughout the day. Again, a reflection of the impact of cognitive load and on decision-making in the healthcare setting. So if we move now to what we can do about that, and on the individual provider level, there's certainly easy access to information. So we know which frequency to provide the colorectal cancer screening or how to address the blood pressure of 132/82 in our case presentation. And there's lots of sources of information up to date, the HIV, the Hopkins HIV Pocket Guide, DHHS guidelines, CDC guidelines. I've shown here the New York State Department of Health HIVguidelines.org because we at Hopkins manage the development of these guidelines, and I guide that process. And we certainly seek to provide guidelines that are easy to use and easy to navigate to increase access to those, and also have some job aids, a bit blurry, but on the left is supposed to be a picture of a printable, foldable summary that can fit in a pocket that has all the summary of I believe that one's for PrEP care. Now I've introduced the New York State guidelines because more recently I've been trying to see if we can increase evidence-based care delivery in New York State using user modifiable EPIC templates, and with Chris Lippincott, who's somewhat of a EPIC guru, we've been developing some EPIC templates well, based on the Hopkins EPIC system, but then later for adaptation for some of the health systems in New York State. And without belaboring it, this just follows for this template example, initial PrEP visit, and takes the provider, if they're not that PrEP savvy, through various considerations that are all based in elements of the guidelines for PrEP use and appropriate dosing, etc. If the individual has syphilis, and can introduce this dot phrase of syphilis treatment that can pull in RPR, but also just within the dot phrase provides the guidelines, including some brief definitions of the syphilis stage, standard treatment, alternative treatment, and the testing interval, again, based on recommendations for HIV guidelines, which are very similar to the CDC STI guidelines. They're built-in, that's all easy to build in. The templates are all easy user additions. There's certainly built-in features that require more EPIC programming. I'm just introducing this because I like it, but I think it helps to reduce some cognitive load and guide the clinician. And this is when ordering dolutegravir lamivudine, just asking, I've highlighted in yellow or shown a yellow box around questions about hepatitis B testing and status to help alert the provider of the need for other coverage for hepatitis B if the patient is co-infected. I'm going to move on from those job aids to something called choice architecture, something many may also be familiar with. This aims to make the preferred choice the easiest choice, whether medically preferred choice or in other fields, the preferred choice also can be called the default choice. And for routine services such as some vaccinations, the goal is to shift decision-making from who should receive a vaccine, which for seasonal influenza vaccination is pretty much everyone showing up during flu vaccination season to the clinic, to who should not receive the vaccine. Thus, the number of decisions go considerably down. Maybe 10% of people should not, well, 90% should. So it switches from making a decision in 90% to only in 10%. So this has a potential to reduce cognitive burden of some decision-making by allowing no decision, the passive accepting of the default in the majority of the situations, and allowing care to be improved, and also opening cognitive bandwidth for other considerations, like understanding the situational depression and the AKI in our patient. I'm going to show some examples. These are classic examples. That's why I've selected them. Starting with non-medical examples of choice architecture. So using the term opt-in versus opt-out. One classic one is for employee or employer retirement savings plans. And some years ago, there was considerable consternation in HR departments about how to increase employee participation in 401k plans. And a lot of different things were tried unsuccessfully. What was tried and successful was simply making the employer savings plans opt out, that everyone was enrolled unless they opted out. And you can see here in this figure that before the opt-out, 37% of employees at this company were receiving the 401k plan compared to 86% after introducing opt-out. A little closer to medicine, this is individuals agreeing to organ donation after living individuals agreeing to organ donation after their death, and comparing the consent process. On the left is people who had to opt into it. On the right is people who had to opt out. And you can see that when people had to opt in, between 5 and 27% agreed to it, compared to nearly 100% agreeing to donating their organs after death if it was an opt-out situation. If we get closer to medical care, this is offering to patients or clients HIV testing. And I like this because of the simplicity of the intervention. This was a study done in multiple EDs in the United States to increase HIV testing. And the intervention started for all patients, and I'll just read it here. We're offering routine HIV tests to all of our patients. It's a rapid test with results available in 1 to 2 hours. And then people were randomized to either opt-in, active choice, or opt-out. And if it was opt-in, the next statement was, you can let me, no, that was the study person, your nurse or your doctor know if you'd like a test today. Active choice, would you like a test today? And opt-out, you will be tested unless you decline. And you can see, if we just look at all patients, the bars, the 3 bars on the left, that for the opt-in in the darkest blue, about 38% of ED patients agreed to HIV testing or had HIV testing, compared to about 65% for the opt-out. So quite a considerable difference with a pretty subtle change in the wording or approach to offering this service. So all of that was not improving provision of primary care, but this has been looked at in a number of ways of primary care, including influenza vaccination. This is a study done in a handful of clinics in Philadelphia area, where influenza vaccination was basically pended in the EMR in the intervention practices and not in the control practices. And you can see that just with doing that, so that when the clinician closed the visit and signed the orders, it would be signed. Influenza vaccine was about 37%, maybe not optimal, but higher certainly than the 27% in the control practices. So this choice architecture certainly has a demonstrated role in some practices in the US. Now, I've mentioned that I'm interested in outcomes and reducing mortality, specifically in low and middle income countries where TB is a major cause of mortality, and multiple RCTs have demonstrated that TB preventive therapy at the start of antiretroviral therapy reduces mortality. So I've tried to think about how to introduce choice architecture to increase TB preventive therapy, which is a little more complex decision process than influenza vaccination, but I think can take a somewhat similar approach. A few years ago, I did a small study with some med students in South Africa where we went into a handful of clinics and where they used paper clinic files and introduced this sticker that we put into an area of the file to bring together antiretroviral therapy prescribing cotrimoxazole and TB preventive therapy. At the time, it was only INH or isoniazid. And then to increase the cognitive load of not prescribing, we asked the clinicians to check off why they did not prescribe TB preventive therapy if they chose not to prescribe it. The primary point of this study was just to look at the acceptability and feasibility, and the clinicians liked it because it saved writing time, because this was pre-filled and they could just edit it as needed. But in looking at the time 6 months prior to doing this, about 68% of individuals received TB preventive therapy compared to 88% of individuals during the intervention period. So I'm scaling that up in South Africa, taking a look at whether a similar approach in a randomized trial cluster randomized trial can increase TB preventive therapy provision. Also, I've looked at doing this in Malawi, or have a study in Malawi to do it, which introduced an interesting option because they have a EMR for prescribing and for some limited amount of patient medical information. And so we introduced this idea to the Ministry of Health and the EMR developer, and they were excited and brought together, similar to that sticker in the South African example, bringing together antiretroviral therapy, cotrimoxazole, and TB preventive therapy. On this slide, you can see 3-HP or rifapentine plus isoniazid and IPT. In fact, they were so excited that they rolled it out to the whole country in every clinic, which has made evaluating the impact a little bit challenging, but we're trying to do that. So there's certainly other approaches to reducing cognitive load or reducing present bias. EPIC templates, Agile MD order sets, and EPIC, mostly in the emergency department and inpatient settings, standard workflows, including workflows that Joyce was just talking about for monkeypox, but certainly for much more common things also. It's certainly a very standard thing, especially in emergency departments. Outpatient order sets, and I would say also simpler management algorithms. And I think the AICP finally caught on a little bit about one of the reasons for low pneumococcal vaccination was the complexity of the algorithms. And now the most recent AICP guideline, I believe, is just give PCV 20 and you don't have to think beyond that. So in conclusion, high volume and complexity of decision-making throughout the medical day of clinical day leads to high cognitive load and eventually cognitive fatigue, decision paralysis, and worse decision-making, including neglecting important preventive care services. Approaches to reducing cognitive load have the potential to improve care delivery, reducing morbidity and mortality, and well-designed clinical tools, including those based in choice architecture, may have the potential to reduce cognitive load and improve the provision of routine care. And finally, I think one of the most important parts of this is that by reducing the cognitive load in the routine, it can open up more cognitive bandwidth for cognitively challenging and creative thought regarding diagnostic and management dilemmas, like managing the depression and the new AKI in the patient that I started this discussion with. So just really thank all of you for the opportunity to talk about this. There's lots of other angles to looking at improving outcomes through improving service delivery. But today I wanted to talk about this and hopefully a little bit interesting and thought-provoking and a good send-off for a long weekend. So thanks so much for the opportunity.
So Chris, thank you so much. There's a couple of things in the chat, but I'm going to just take the moderator's advantage of asking you a few things myself. So I just find this so fascinating. I also feel like many of us probably, I mean, I feel like now 2 years into the pandemic, I feel like my decision-making fatigue has reached levels that like where every day you're managing risk in ways that are different, and probably has sort of sneaked into some of my work decisions as well. But setting that aside, I had asked about whether or not the present bias impacts both the provider and the patient. But as you were talking also about the cognitive load, like I have this tendency to try to address fewer things with patients at each visit, which is, I think, a combination of present bias, but also a combination of like wanting to reduce what I'm asking the patient to do, even though it's much more efficient to like give them the whole list of like the 42 things. And I wonder if there's like another side, like if you tell someone to get a colonoscopy, their routine podiatry visit, follow up in nephrology, have their screening ultrasound for their Hep B, like, are they less likely to do any of those, or how does that work? Do you know?
It's a great question, and definitely there's the other side of this, which is the patient. So I don't have a specific answer to that, and I'm actually not aware of studies that have looked at that specific question. But definitely getting there's a lot of work that I try to build on a little bit on the patient adherence side. So other stuff I do is just around getting patients, again, mostly LMICs related to HIV and TB care, and not necessarily getting their podiatry visit for diabetic feet. But certainly in terms of understanding the patient capacity to do that. Some of the work in the US in terms of, I think, is related to some of the, related to cancer care, where there are a lot of visits, and then some of these trials using patient navigators, not necessarily directly addressing some of the behavioral economic sides of present bias and cognitive load, but trying to assist a patient that has a lot of demands in terms of their medical care.
And then I see 2 points in the chat that seem related to me. Yuka was asking if anyone had evaluated the NEPOs, so the non-provider initiated orders. And then Greg Lucas is mentioning task shifting as a way to put some of these preventative tasks addressed by a trained non-clinician. I'm just wondering if you had any comments on those sorts of things, sort of building into workflows so that we actually don't think about them, they just happen.
Oh, I think those are both, I think they're NEPOs and the task shifting very related, but definitely if somebody is, I mean, I think if you think about something like blood pressure screening, we've task shifted that to an MA rather than us doing blood pressure screening, or only half our patients would get blood pressure screening. And similarly with queuing up influenza vaccination or other seasonally indicated things. And certainly there are other opportunities for task shifting that are done in a variety of settings, including some we could go into in low and middle income countries.
So Yuka, go ahead.
Yeah, great talk, Chris. Just to add on about the NEPOs, though, it is the other side of it is a financial thing. So if you have a lot of MA turnover and you have to keep training people to do the NEPOs properly because they're not getting paid well enough and so they turn over, there's also a workflow issue where more things get forgotten because people are assuming that they're getting done. So if someone does do that evaluation, it'd be really important to think about that as unfortunately, it's not mitigating, it's sort of a confounding factor worth considering. So I love NEPOs, like for hemoglobin A1C, I think it'll work great. But I think there's some things where like it gets done and then someone doesn't look at it, or it doesn't get done because someone doesn't realize that they're supposed to do it and check the chart to see if someone hasn't had one in the last 3 months.
So Yuka, how about we increase the salaries of MAs so that we can retain the good ones?
Yeah, so I have been arguing for that for 4 years, and they they're increasing, and they have now more than one like level. There used to only be one level, so now you can be like a senior MA. It's not called that, but it's like a better salary. But it's taken a really long time, and I think now with inflation, it's like they didn't even get a raise at all. So now I don't know what to do, but I will pass the baton to you, Chris. I think you will help get more money for them.
Whatever I can do, Yuka.
I see that Jean has her hand up. Please go ahead.
Yeah, Chris, thanks a lot. That was great. And there were so many things to think about. But when we start talking about not overwhelming our patients, I was reminded of what we do in outreach, that we actually set goals for them and we try not to overload them with the goals, maybe having 1 or 2 or 3 goals that they can address within like a 3-month period. So that, and have it written down so that they actually can achieve those without feeling overwhelmed. So it's a thought to try that with primary care as well.
Yeah, definitely. Good point, Jean.
And Chris, I had one other question, and I'd love to hear if like Joko or some of the other high volume providers. So I do experience the cognitive load quite differently in clinic versus inpatient. Inpatient, I don't feel like at the end of the day, like sometimes I feel like I make even better decisions, but it's a different sense when the patient comes and then leaves, and there's that brief period for the encounter. Whereas I think in the inpatient setting, you can continue to think about and revisit decisions later in the day. I just wonder if there's any work on that, or if that's just my personal experience, which is not shared.
I'm not aware of any work. I mean, the total number of decisions, at least when I'm on inpatient consult, you may make a lot of more decisions than I do, I think is much lower than my typical clinic day where I'm making, it seems like tons of decisions. Many of them are very minor, but each one, I think one major point is that they add up. In terms of tools of measuring cognitive load, there certainly people have tried. I mean, there's lots of tools for measuring cognitive load in non-medical settings. And in some of the work I'm doing in South Africa, I've tried to adapt some of those tools and are testing them to measure provider cognitive load. Still have some way to go before I bring it to the inpatient and outpatient setting of Hopkins to try to do those measurements.
So Yuka's assigning you an editorial in the chat, which we would all love to read, but did anyone else have any questions or reflections? I really want to try to take some of these principles into how I approach clinic, even if also just like clearing my brain before I arrive there, to at least start from that good point at the beginning of the clinic day. All right, well, I will take that as the appropriate Zoom wait time. Thank you so much. This is really gave all of us so much to think about, and I think some really practical ways to reassess our own decision making and try to approach things better. And I look forward to the increased salary for the MAs and all the new Epic Smart tools that will make us do an even better job. Thank you so much, Chris.
Yeah, thanks, Eileen, and everyone else. Thanks also for all the great suggestions and comments. Really appreciate it.
Have a great holiday weekend, everyone.